Miyam natong alakalakya non atach talmangay no Tenglish UC San Diego ungan Tenglish pilachilanga pilachik. Hello, everyone. Welcome to our programming session for J21 titled Tribal Sovereignty and Healthcare. My name is Alec Kalak. I am the delegate for the Association of Native American Medical Students, currently serving on our Committee on Global and Public Health. And I'm excited to share the session with all of you with the Minority Issues Committee. As we dive into this session, I hope we can truly explore the underrepresentation of American Indians and Alaskan Natives in medicine and issues faced not just by those communities, but by the broader academic medical community as well. Introducing our speakers, we have Dr. Mary Owen. She is a member of the Tlingit Nation. She graduated from the University of Minnesota Medical School and North Memorial Family Practice Residency Program before returning home to work for her tribal community in Juneau, Alaska. After 11 years of full-scope family medicine, she returned to the University of Minnesota Medical School Duluth in 2014 as the director of their Center of American Indian and Minority Health. Her work includes developing and managing programs to increase the numbers of American Indian and Alaskan Native students entering medical careers, outreaching to local and national Native leaders to ensure that the University of Minnesota Medical School remains in tune with American Indian healthcare and education needs, as well as developing an American Indian and Alaskan Native track to prepare all students interested in providing healthcare to American Indian communities, as well as developing research to address American Indian health inequity. She continues to provide clinical care at the Center for American Indian Resources in Duluth, Minnesota, and is the current president of the Association of American Indian Physicians. Our second speaker is Principal Chief Chuck Hoskin Jr. He was elected to serve as the Principal Chief of the Cherokee Nation, the country's largest tribal government with more than 390,000 tribal citizens in 2019. Prior to being elected Principal Chief, he serves as the Cherokee Nation Secretary of State. As Principal Chief, he has increased the minimum wage at the Cherokee Nation and Cherokee Nation businesses and secured the largest language investment in the tribe's history to expand Cherokee language education and preservation. He also appointed the tribe's first delegate to the US Congress, doubled Cherokee Nation's funding for career tech education, and established the Housing, Jobs, and Sustainable Communities Act to repair hundreds of homes for Cherokee elders, as well as public community buildings across the tribe's 14-county jurisdiction. Additionally, as Secretary of State, he worked to secure funding from the federal government to fund $1 billion joint venture investment in better healthcare for all Cherokee people, and has also served as the Cherokee Nation's strongest advocate on sovereignty protection. And our final speaker is Dr. Daniel Joseph Kalak, who also happens to be my father. He has served as the Chief Medical Officer for the Indian Health Council in North County, San Diego since 2003. He was raised on the Palma Indian Reservation and graduated from San Diego State University. He attended Harvard Medical School and completed his internship and residency at USC LAC Combined Med-Peds Residency Program. He is a member of the Palma Band of Luiseño Indians and is actively involved in his community. His professional interests include chronic disease and clinical research, and currently serves as the PI for the California Native American Research Center for Health, which is an NIH-funded project providing a platform for community-based research with American Indian and Alaskan Native communities. He also serves on a variety of committees, providing his expertise on the national stage, and is a truly inspirational leader, not just for me, but everyone he works with. So with our introductions, we're going to dive into our panel, and I'm so excited to speak with all of you who I consider leaders in each of your respective fields. And as a medical trainee, it is certainly a pleasure to be connected with all of you. So looking at the current state of Indian country, and as vaccines are more and more available, I truly think that our recovery from COVID-19 depends on the strength of our healthcare systems, and investments in healthcare and education have never been more important. So my first question is for Dr. Owen. From your vantage point as the president of the Association of American Indian Physicians, what issues do you see in training a workforce for Indian country? The Association of American Medical Colleges has described the continued underrepresentation of our people in medicine as not just a problem, but a crisis. What is your view on all of that?
Well, I'd agree it's a crisis. If you look at over the last 40 years, our matriculant rates of American Indian students into medical school has actually decreased. So, and it's not as if our health disparities have decreased, they've increased, right? Our needs have increased while our numbers have decreased. And there are lots of different reasons for this, but I think it'll be imperative that the Indian Health Service, the federal government under President Biden, use some of the funds that they're using to help us rebuild infrastructure, that they use some of that to help build the infrastructure of Native education. And that would, for me, one of the biggest reasons that we don't have enough people matriculating to medical school is obvious. We don't have enough students graduating from high school. We have in Duluth, Minnesota, where I live, we have a 50% high school graduation rates for our Native students. So people keep saying that's too far down the line and don't want to address these. I hear that frequently. They always want to talk about us in medical school and what we do here. That's critical, but as critically, we have to address those little people. We have to start and develop a pipeline from K to practice. That's the only way we're going to change this picture. And it's because those same social determinants of health are the same social determinants of education. Our communities are suffering from poverty, and not all natives are impoverished. I know that, and I don't want people to think that I would say that, but enough of them are. For instance, on some of our reservations where there's 40% poverty, that actually means that 60% or more people are not making it. And if we don't address that, we're never going to get our kids through the school system, into education and all the other places that we need them to be to advance. So some basic social determinants of health, address those, and we'll be addressing social determinants of education and increasing those numbers of kids going through the pipeline and getting to where we need them to matriculate into medical school.
Thank you so much, Dr. Owen. The issues faced by Indian country are certainly innumerable. And at a time where we're pushing for racial equity and kind of seeing the deeply rooted structural inequity across Indian country, such as chronic underfunding of the Indian Health Service, inadequate public health infrastructure, really how that infrastructure was built around us and not with us, as well as the kind of impact of structural racism in our communities. I see, with everyone saying the term BIPOC, Black, Indigenous, people of color, the I is often lowercase, and there's an asterisk where it's Indigenous communities referred to, but not represented. And when we think about how invisible these problems are in our society, I'm reminded of work that you've done, Chief Hoskin, where on the Cherokee Nation Council, you worked to increase education funding and sponsored legislation to expand healthcare service through casino dollars. And when we think of casinos in Native American communities, I had a physician tell me in my first year of medical school that the only thing that I need to know about Native American health as a future physician is that if a tribe has a casino, they have great healthcare. And trying to push back on those harmful narratives, it's difficult. So how has the Cherokee Nation really worked to create infrastructure with casino dollars? And also, if you could kind of dive into kind of how those dollars support critical infrastructure, not just for the Cherokee Nation, but Indian gaming across the country.
Well, I appreciate the question, and I appreciate being on the panel with everyone. If you look back, and you don't have to go back too far in the Cherokee Nation and tribes across the country, you can see healthcare largely delivered by the government of the United States through the Indian Health Service. I was born in the Claremore Indian Hospital, Claremore, Oklahoma. Most of my life, I lived in a time as a kid in which healthcare, again, was delivered by a federal agency. Now, and it's been on a steady progression over the past few decades, thanks in large measure to gaming, but also some of the self-governance efforts that Chief Mankiller undertook in the 1980s. We have been able to chart our own destiny for healthcare. I like the comment earlier about the healthcare system being built around us and not for us. We're building a healthcare system for the Cherokee people, putting the patient at the center of that. So we have across our reservation, we have all new healthcare facilities. And you look at the United States, you look at the Indian Health Service, they're about $1 billion behind on healthcare infrastructure in this country. Cherokee Nation, we focused on our future, and we put those gaming revenues and other revenue into building up new clinics so that we have state-of-the-art facilities. The flagship of those of the health system, and we have about 9 outpatient clinics and our hospital, is our new largest in Indian country outpatient center, which is state-of-the-art facility, has all sorts of services. It's the type of healthcare system and range of services that I think if you ask most Americans, would you like this to be accessible to you? I think most Americans would like it. And I think it's good to live at a time and be in a leadership position when our system actually is head and shoulders above the rest of the region. The region I'm in being Oklahoma, where the health outcomes are very low. All sorts of statistics are going in the wrong direction. But I think Cherokee Nation, because we have made healthcare a priority, we are rising above that. So you look at our healthcare infrastructure and you look at the fact that we put money into healthcare education. You mentioned that. And so we are trying to inspire this young generation of Cherokees to be the doctors and nurses of tomorrow. And we've given them a place to go to med school with the Oklahoma State University Med School here in the Cherokee Nation. But the real great challenge is something that was mentioned earlier, which is you have little boys and girls, little Cherokee boys and girls, and you want them to become doctors and nurses. How do you put them on a sustainable path from birth to college and med school to do what we all want, which is to be them to be the doctors and nurses tomorrow? It's a enormous undertaking, and it takes resources. We're trying to do that at the Cherokee Nation with those gaming dollars and those other business dollars.
Great work, Chief Hoskin. And, moving to, my father, you, Dr. Kalak, have served your tribe's healthcare needs for nearly 20 years, and you're providing care to the same community that you grew up in, especially as a recipient of the Indian Health Service Health Professions Scholarship. And just a few weeks ago, the National Health Service Corps Loan Repayment Program dedicated $15 million in additional awards to clinicians working at IHS facilities, tribally operated facilities, and urban Indian health programs. So how important was it for you to have that scholarship support to be able to return to your own community, and kind of what, gaps still remain in funding, thinking of the IHS scholarship programs as well as the National Health Service Corps ones?
Thank you. It's a distinct honor to be on the panel today with Dr. Owens and Chief Hoskin. And to the question, many times in American Indian education, whether it be in STEM fields, medical fields, or other fields, there is often a non-traditional path that is taken by many students, and it touches on a variety of factors that Dr. Owens and Chief Hoskin touched upon in terms of the availability of resources, the availability of advocates, mentors, additional supports that lend students down that path to succeed. And I definitely took that non-traditional path. I was an older student going into undergrad, and then into medical school. I already had one child, Alec. And during medical school, I had 2 additional children, one in medical school and one in residency. So that combination of factors support the need to care for a family, the need to be focused on your studies, the need to be competitive, especially in the fields of medicine as it pertains to either medical school, graduate schools, and or postgraduate training as pertains to residencies, factors into many of the issues facing medical school graduates. Now, definitely the support that Indian Health Service scholarships and National Health Service scholarships provides is a much needed resource. I think Dr. Owens touched upon this briefly in the need to have those supports for American Indian students and or graduates. If not for the Indian Health Service scholarships and or the support of our tribe, my tribe specifically, in providing some support, either monetary and social cultural support, was so imperative in making sure that I could continue to succeed in my endeavors, whether it be in medical school and or postgraduate training. So the idea is that there are enough scholarships out there is, I think, only limited by the number of graduates and applicants that are willing to apply. And it has been one of my endeavors here at the Indian Health Council as the Chief Medical Officer here practicing in Southern California for the last 20 years, is to making sure that medical education and medical access is one of the priorities, not only of my career, but thankfully of the area and of the tribes that we service. We've actually had many students that have passed through the clinic that I service, and more recently have been dedicated to working with our academic partners locally to make sure they have the same experience and the same opportunities.
Thank you, Dr. Kalak. And, I always think back to this quote from Judge Steve Russell, and he said, "The group at the statistical bottom of all the scales thought to measure lack of opportunity is American Indians. However, a line of viable Supreme Court authority holds that equal protection of the law does not require strict scrutiny of laws, singling out Indians for advantage or disadvantage when Indians is understood to mean members of federally recognized tribes rather than Indians by race or ethnicity." And I say all of that because the AAMC and AAIP have really called for transformative thinking and a new systems-based approach to address these workforce challenges. So I wonder, what case is there to make a distinction between American Indian and Alaska Native self-identification rather than membership in a federally recognized tribe, especially as we start to think about how states have started to outlaw race-conscious admissions policies for things like affirmative action? How does that kind of interfere with the ability of AAIP or tribe themselves to fulfill the critical needs that they see in their own communities? And I guess this is more of a kind of open question, first to Dr. Owen and then Chief Hoskin.
Our school has actually been approaching this differently for a long time. People have self-identified. We don't ask anybody to prove their nativeness. And I believe wholly in that. One of the best things to me about AAIP is this ability to pull people in, even if they have been outside the community, but know that they're native, pull them in and say, you have something to give and you can, and you shall, and here's how you do it. And we teach them how to do just that. But you have to accept people and make them strong and proud of being native. If you don't acknowledge that, then they're lost potential, and we don't have room for lost potential. So my school I am on admissions and have been for 4 years, and what I look for is a student who is, I'll tell you what I don't look for. I don't look for box checkers. I don't want anybody who just says that they're native. That's not good enough. I want someone who is committed to serving Native people somehow, some way in the future. And that isn't necessarily designated by the amount of blood you have. When I think about heroes in this whole debate, I think about the Red Lake Nation, who recently stated anybody born before 1953, I think they chose, I can't remember the number, is now a full blood. So they wrote their own rule on this, and it comes down to sovereignty again. We get to decide who is native as Native people, right? We get to decide ourselves and as our tribal governments. And as far as us being political, that's the other reason the University of Minnesota has done this, is that or the other piece that's critical the University of Minnesota has done is to say Native people are a political group. They are not, you can't say that we admit too many based on race, because they're not a race. They are a political group. And the United States has confirmed over and over, or at least the Supreme Court has, the legislature has, and the executive body, that Native people have different rights, sovereign rights, including the right to health care that they'll provide. So.
Thank you, Dr. Owen, for all of that, and truly being inclusive and really respecting I guess, the politics of, sovereignty and tribal membership, and truly wanting to be inclusive of all students, is truly important. And, as we start to kind of near the end of the session, something that was very interesting to the Association of Native American Medical Students was reporting from High Country News about the history of land-grant universities and how this system of colleges and universities is still deriving monetary profit from land that was given to them by the federal government during the construction of the Transcontinental Railroad. And I have this figure here that I think is truly kind of enlightening, with two examples of land-grant medical school systems, the University of California and Cornell in New York State. And when you think about the underrepresentation of Native Americans in medicine, I believe about 43% of US medical schools have no Native American medical students, and just over half have no more than 3, and 9% have 4 or more. So in kind of thinking, and this is more of an open reflection, how can academic medicine be a stronger supporter of these challenges, and how can they kind of meet us where we are, as opposed to kind of giving 80-20 or 90-10? How can we be right in the middle at 50-50? The American Medical Association is the leading voice for physicians in the country, and as a membership-driven organization, the representation of American Indian and Alaska Native physicians and medical students is fairly tiny. So how can we kind of amplify those concerns and really drive that into policy making as well as advocacy?
I know that other people deserve a turn, but I have to interject one piece that's really critical, I think, to this, is that we need to get Native people, Indigenous people listed as a requirement as part of the LCME requirements. These schools need to have a mandate to include us, just as they do with African-American students and in faculty as well. Because if you don't have the faculty, you're not going to draw the students. They need mentorship. So, and there is an effort in New Zealand. It's been around for over 20 years now, New Zealand and Australia, called the LIME, Learners of Indigenous Medical Education. And they were able to push through this standard that's now the norm for all of their medical schools. I'd like to hear my partners talk here, my colleagues.
Well, I would just say that the imposition of institutions like land-grant universities, the impositions of the railroads across tribal lands, the imposition, frankly, of the state of Oklahoma over many tribal lands, as generational impact in a negative way, and you can measure it lots of different ways. And this is an opportunity here in 2021 going forward to have a positive generational impact if we can get more of our people into medical school, quite simply. And I think the schools ought to recognize where they came from. I think they ought to recognize the lands that their forefathers imposed upon. With Oklahoma State University, which is a land-grant university, we have a great relationship. We've been able to create the medical school environment here in Tahlequah that's very respectful of our traditions, and I think just as important, creates some opportunity for Cherokees to go to medical school. We've got a percentage of Native med students in this country that's too low, but I think we're outpacing things at Oklahoma State University. We're putting some dollars on the table to recruit and to help those Native students go to Oklahoma State University. So I think when institutions recognize where they came from and can meet the obligations that come with that, with frankly some finances and some commitment to open up slots for med students, I think that's what ought to happen. But we've got a cooperative relationship here in Oklahoma with Oklahoma State University. It's working quite well.
Thank you. Those are two thoughtful, insightful comments. And I think to add on, the amazing 1% rule that has been so persistent. So either it's either you're 1%, less than 1%, or you're NA if you are identifying as American Indian, and you're looking at cancer incidence rates. You're looking at rates of of any other type of major morbidity across the spectrum of medicine. And those well, the 1% are so difficult to move, for a variety of reasons. One is that persistent mistrust that is there in American Indian communities, Alaska Native, Pacific Islander communities, Hawaiian Brother communities that persist and almost disallow the enrollment and the participation of addressing these same issues. And the same exists in research, whether it's community-based or it's academic. Now, interesting that academia really overlooks the true meaning and the altruism that it is bound by in improving the overall condition of man, and the importance of looking beyond that and engaging these gaps in knowledge, and that actually turn into gaps in the deliverables of knowledge and public health measures that can significantly improve the health of not only American Indians, Alaska Natives, and Pacific Islanders, but as a human as humankind in totality. It's so important. It's actually so aggravating to actually note that 1% has persisted, for such a long time, over hundreds of years. And so I'm really looking forward to actually some more notoriety around the 1%, around what medical associations like the AMA can do to bring to light some of these vast discrepancies that have been persistent for so many years. And now that they're being brought to light, even in a digital age where it's much more apparent about what's going on, thanks to advances like the internet and the ability to see what's really going on minute to minute, second to second, in a variety of communities across the United States, hoping to see bigger and better things, and actually increasing the 1% to see what's really going on.
Thank you so much, Dr. Kalak. And kind of reflecting on how the reality today is that for many Native medical students at their institutions, they feel like the only one or one of the few. And I was the only Native medical student in my class of 134. And just 2 years later, there were 5 first-year medical students who were Native American. And in that moment, I was really excited. But when we look at the continued reporting of kind of this flat representation of Natives in medicine, or even a decline really in the last 40 years, I kind of thought, the gains at one institution likely translate to losses in representation at another. And it's this kind of constant shuffling where really the numbers of students applying and matriculating are not anywhere close to where they should be. And I think this is our final question now. Just as a mirror reflects an image, I think I can say the same about an institution's mission statement and its values and its curricula and its values. And, with just 11% of medical schools teaching anything about Native health, I look to, say, the University of Minnesota's medical school, where, you have Native healthcare and education in your mission statement. And please, Dr. Owen, correct me if I'm wrong, I believe over 10 hours of Native American health education content for medical students. How does that kind of change the landscape of medical education? And how can that be a model for other institutions?
I think it's been fantastic that we've been able to hold on to that. And we've had it now in place for 6 years, but I'm at the point now where I'm realizing it's not enough. So it is so important, but yet unless you teach students how to take that knowledge and use it, then you're not going as far enough. So I will push people to go further than we are, and hopefully we will be soon. So it's been really well received. I can't believe the number of students, non-Native students, who come up and say, we had no idea. Because our schools, our K through 12 schools, are doing such a poor job of telling history the way it should. Students learn about Natives as Trail of Tears and maybe Wounded Knee, and then we died after Wounded Knee, right? So they are shocked. Students in Minnesota don't even know the tribes, that there are 11 bands here or 11 tribes here. So those bare bone basics, again, not enough. They need to know now, what does that mean? What do those health disparities mean? How do we change it? But I don't think it's just in Indigenous education, right? It's in all those social determinants of health that Dr. Kalak and I both know are, 80% of what we take care of in medicine and need to be taught. So as that moves along, so I think we should be applying that to the Indigenous health lessons. So yes, other schools, please take on this Indigenous medicine and health. Make your students know the bare bone basics about us, but then tell them how to go the next step and how to use those lessons appropriately and take care of our patients.
Thank you so much for leaving us with that, Dr. Owen. Dr. Kalak, did you have some parting words?
Yes, I think I didn't want to cut off Chief Hoskin. I see we're reaching for the mute button at the same time, but I just like to echo those same comments and actually your analogy of the mirror. And so, really reflecting, back on the current status of American Indian healthcare and the relationships that exist within the U.S. government, and looking at the children that we care for every day and that we see not only in the communities that we live in, but in our clinics that we provide care for. And so, the rates of obesity, the rates of adverse childhood events that persist and they're markedly elevated, that translate into chronic comorbid conditions of high blood pressure, diabetes, depression, and which exacerbate the underlying social issues that people contend with on a day-to-day basis, depression related to their mental health status. And if you lay on top of that the factors, the issues that some of the two-spirit people actually have to live with, and these factors exacerbate and multiply the components that people have to contend with in their communities. And looking at that mirror, that is what the relationship and that has evolved in and created, and that persists. And thankfully, people like yourself, Alec, and Dr. Owens and Chief Hoskins are there actually to remedy. And so on an up note, we are available. I should say, I shouldn't speak for them. I am available at any time to address and to come and to meet with the American Medical Association and or Congress to help them understand. And it could be actually small as Rotary clubs and community events. Those are the venues that we may start with, but really looking at the mirror to facilitate some more improved and deeper discussions about how we can make some effective changes that'll be long lasting, because essentially what we're looking at is a perpetual genocide of the communities that exist right now.
Thank you so much, Dr. Kalak and Dr. Owen, for imparting those words with us. And I truly wish that we could continue this conversation for hours on end, because we don't often talk about these issues in spaces like this. And I am so grateful to the medical student section for facilitating this, but also understanding that this is just one event and one conversation, but these are the conversations that have to happen daily, year-round, if we are to make a difference. Chief Hoskin, I want to commend the Cherokee Nation for opening the country's first tribally affiliated medical school. Seeing that as a true testament to the leadership of your tribe, as well as an example of what we should be doing. And I always like to say that advocacy is to change what is and what should be. And across Indian country, there are a lot of things that should be as we start to think about broken treaties and the obligations that are unmet by state and federal leaders. So thank you so much to the three of you for your time. And I'm so happy to be here, but also continue this conversation the next day and the next day, years forward. Thank you.